Good afternoon, everyone. Dear Professor Mills, dear Professor Nichols, dear audience. It is my pleasure to present you our findings on the neutrophil lymphocyte ratio in the early diagnosis on acute myocardial infarction. So, I don't think that I need to deeply introduce the problematic of acute myocardial infarction and of the rule out or diagnosis of acute myocardial infarction. It is very largely represented among the patients presenting to the emergency department. And currently, as every one of us knows, there is one established biomarker, and it's the cardiac troponin. But what's the neutrophil to lymphocyte ratio? As the name suggests, it's the absolute neutrophil count divided through the absolute lymphocyte count. And it can be a marker of acute stress. In the past years, it gained a lot of attention. It was evaluated also in correlation with cardiovascular diseases or with higher mortality in cardiovascular diseases, but also in many other diseases like infectious diseases or cancer. And why neutrophils in acute myocardial infarction? It's known that atherosclerosis is based on an infectious process, so that is one thing that contributes to the increase of neutrophils in acute myocardial infarction, and also the necrotic process occurring in acute myocardial infarction can amplify the release of neutrophils and hereby increase their absolute count. Despite this, there are no data on the diagnostic performance of the neutrophil lymphocyte ratio together with high sensitive cardiac troponins. So, what we did, we used the cohort of EPACE, which is a prospective multicenter international cohort study enrolling unselected patients presenting to the emergency department with acute chest pain, and the final diagnosis is adjudicated. The EPACE cohort has 6,684 patients, and those patients in which the neutrophil lymphocyte ratio could be counted were 3,476. We assessed the diagnostic performance using ROC curves or receiver operational characteristic curves and counting the area under the curve. And we also assess the prognostic value by doing a survival analysis which was adjusted for possible confounders. As we can see in this box plot, the neutrophil lymphocyte ratio is mostly increased in the group of patients with acute myocardial infarction in comparison with the other gold standard diagnosis used in the EPACE cohort, but there is also an overlap in between all of the groups. So, now to the diagnostic performance. The AUC just for the neutrophil lymphocyte ratio alone is 0.64, which is actually bad. So it seems not to be a good diagnostic biomarker for acute myocardial infarction. And we can also see that it does not bring any additional or incremental value when we combine it with troponin, with high sensitive troponin T. The area under the curve remains the same. For high sensitive troponin T alone, it's 0.94, and in combination with neutrophil lymphocyte ratio, it's still 0.94, which is also confirmed by the DeLong test with a non-significant p-value. The same results can be reproduced when we take high-sensitive cardiac troponin I. Also here there is no incremental value of the neutrophil lymphocyte ratio when we add it to the high-sensitive troponin I. To the prognostic value, here we can see a dose response plot which shows a restricted cubic spline and treats the neutrophil lymphocyte ratio in a continuous manner. The restricted cubic spline has 3 knots in order not to impose linearity. And we can see that the relation between the neutrophil lymphocyte ratio and the outcome, which is 1-year mortality, is non-linear, and that it increases with the neutrophil lymphocyte ratio. That means there is higher 1-year mortality in patients presenting and having a higher neutrophil lymphocyte ratio. So when we summarize it, we have some limitations. In our cohort, unfortunately, there were some informations missing which would be interesting as possible confounders with neutrophil lymphocyte ratio value. For example, the diagnosis of infectious disease or the intake of some medications which might have an effect on the leukocyte level. And we also excluded patients with terminal kidney failure. And what we can conclude that there is no evidence of an incremental value in the diagnosis of the acute myocardial infarction when we take the neutrophil lymphocyte ratio alone and when we combine it with high-sensitive cardiac troponin T or high-sensitive cardiac troponin I. And we can also say that an increased neutrophil lymphocyte ratio correlates with a higher 1-year overall mortality in patients presenting to the emergency department with acute chest pain. Thank you for your attention.
Fascinating data. I really enjoyed that. I always like it when another biomarker goes up against cardiac troponin and fails. But it's a tough ask to beat high-sensitive troponin as on a diagnostic endpoint. But there may still be some value in neutrophils and lymphocytes. And I guess my question really is about the endpoint. As Christian mentioned in the previous presentation, combining type 1 and type 2 myocardial infarction as a non-STEMI endpoint doesn't really allow you potentially to use the value of this biomarker to help discriminate between maybe a type 1 event or a type 2 event, which is much more likely in the context of infectious diseases and other illnesses. Have you, reversed the question, looked at the endpoint separately of type 1 myocardial infarction?
Not yet. But our analysis is just at the beginning, so there is some space for deepen it, and we can consider your suggestion.
I think it would be interesting. I think we all are struggling with identifying good biomarkers to differentiate those two presentations, and if there was some insights there, it might be helpful in practice. Second question is, you're also giving, it's pretty tough because if I understand your analysis correctly, it's peak high-sensitive cardiac troponin is your comparator, whereas presumably your ratio is only done at one time point. And I assume that the lymphocyte neutrophil ratio, given it as an acute stress response, will also change over time in relation to the onset of ischemic pain and as necrosis develops. So is it a fair comparison? I guess is what I'm asking.
I mean, this is also something we can consider, but we did not do an analysis for that so far. But I think that it could be a fair comparison, especially because of the necrosis present in myocardial infarction, which also develops in time and not only influences the troponin value, but also influences very probably the neutrophil lymphocyte ratio value. So we could do an observation of the neutrophil lymphocyte ratio in serial measurements.
I think that would be interesting. It also be interesting just to look at the two biomarkers themselves, of course, the neutrophil count and the lymphocyte count, particularly in the prognosis analysis, rather than just the ratio. But really interesting data. In the interest of time, we'll move on to the next presentation. Thank you.